absolutely. Let's get started.
Okay, so hi everyone and welcome to today's Reverse Rett Bite-Size session. These sessions are being brought to you by a new project at Reverse Rett called Rett Connect, which is funded through the PAIRS Foundation. As always, we're going to start with a half-an-hour presentation followed by a question and answer session at the end. As I'm sure everybody here knows, with Rett syndrome, we're dealing with an awful lot of symptoms, and those are very varied and can cut across lots of bodily systems. And that makes it very difficult to manage, obviously. Sometimes with one treatment for a particular symptom exacerbating another, or the symptoms exacerbating each other. So today we invited some of the team from the Centre for Personalised Medicine in Rett syndrome to speak to us about some common health issues in Rett syndrome. This team have been working with patients with Rett syndrome for a number of years through the Centre for Interventional Paediatric Pharmacology and Rare Diseases at first, and then now through CPMRS. And also in 2017, this team initiated the first UK clinical trial for a potential treatment for Rett syndrome. Now they're managing around the health of 125 complex patients with Rett syndrome up and down the country. So with us today are Dr. Samiya Chishti, Tilly Mastroianni, and Dr. Salah Basheer from the CPMRS. So while the team are happy to answer questions, obviously they can't offer specific medical advice on individual cases, but they can share their experience of common issues encountered by patients with Rett syndrome and then reflect on the different treatment pathways. If you do have any questions for the team, you can feel free to pop them into the chat box throughout the session, or you can raise your hand, actual hand, or you can go to your 3 dots in the corner of your screen. No, that's the wrong thing. Wesley, is it reactions? Yes, it's reactions. So you can go to reactions and then click and then put raise hand up like this. And then the other thing is, please could you keep yourself on mute throughout the session just so that the sound is good, and then when you want to answer a question you can obviously unmute yourself, ask a question rather. And then the other thing is we will record the session today, so if you don't want to be recorded, please just turn your camera off. And I think that's all I have to say now. So Dr. Samiya, Dr. Salah and Tilly, welcome and thank you for being here with us today.
Thanks. I'll just share my screen. Forgive me, my tech isn't wonderful. Okay, can everyone see? Yeah, perfect. Okay, so as Rachel said, we're going to be talking about common health issues in Rett syndrome that we see in the CPMRS. So we'll just introduce ourselves to start. So I'm Tilly. I'm an assistant psychologist and I'm the clinical service coordinator for the CPMRS.
My name is Samiya. I'm sorry, my name is coming as my daughter's name because she's been using the laptop for a class, so apologies for that. And I am working as a specialty doctor in CPMRS.
Hi everyone, my name is Salah. I'm also working as a specialty doctor in CPMRS. Nice to meet you.
So today we'll kind of do I'm going to give you a little bit of background of kind of the CPMRS, who we are, sort of what we do, even though I'm sure some of you know. And then we'll go over some of the sort of common symptoms and symptom areas that we see in our patients. And then Salah will talk to you about emotional, behavioural and autonomic dysregulation, which is our sort of area of expertise. And then Sami will kind of round off with some of the more medical problems that we see. So as Rachel said, we're the Centre for Personalised Medicine in Rett syndrome. We're a national centre with clinical and research arms, and we see patients of any age. So we currently have about 130 patients that range from about 2 years old to about 50 years old. We aim to treat our patients holistically. So as you all know, Rett affects a lot of different systems in the body, but we try to look at the patients as a whole and all their symptoms together rather than just focusing in on one particular area, because everything's sort of quite interlinked with each other. So we offer assessment and intervention to our patients, but we also offer support to the families as a whole, and we also kind of liaise with schools and social care and kind of our other colleagues to help sort of patients care across the board. As I've already sort of briefly said, our area of expertise is more the kind of neuropsychiatric difficulties and the emotional, behavioural and autonomic dysregulation that we see, which we'll go into a lot more detail about. But we do have a very kind of close relationship with a lot of other colleagues and other specialities, and we can make referrals and things to help with the symptoms that we can't directly manage ourselves. And we also do a lot of research in the centre. So as Rachel said, we run clinical trials, but we also write a lot of papers. We kind of use our questionnaire data and things to just generally help to spread the word about these sort of treatments and things that can help patients with Rett. So I just give you a very quick sort of overview of what we do in the centre with our patients. So people get referred to us from a lot of different places. They can come from your GP, from a consultant, from Reverse Rett, or people can self-refer to us as well. So when people are first referred to us, we ask that they complete a few online questionnaires, which help us to get a really good idea of the sort of full symptom profile. And then we assess the patient using several different methods. So we have really detailed conversations with the families to get as much information as possible. We use the information from questionnaires, and then we also use sort of ECGs and blood tests and watches to help us sort of build the picture, and then we can use this to plan what treatment a person might need. And we follow up with the patient regularly, but Samiya and Salah will go into more detail about the ways that sort of these methods can help us manage our patients. So this graph is kind of just an overall outline of the kind of symptoms that we see in our patients. So we use a questionnaire with our patients called the REST questionnaire, which assesses every symptom area you can possibly imagine in our patients. And this graph has kind of used the data from that to give an idea about how sort of prevalent each of these areas are. So as patients experience difficulties across the whole range, some more than others. So like motor symptoms includes things like, the hand movements and things like that. So that's sort of very prevalent, but the rest are sort of quite evenly spread across everybody. So we have to manage sort of all these areas. I'll pass over to Salah to sort of talk a bit more about the emotional and behavioural side of things.
Good morning again. So as you all know, Rett syndrome is a complex neurodevelopment disorder, and it is caused by MECP2 gene mutation, and that causes changes in the brain in various areas. And what we see is that it causes, the key term is the dysregulation of many aspects of our functioning in terms of behavior as well as autonomic. So Rett syndrome is associated with emotional behavior dysregulation independently, as well as Rett syndrome is also associated with autonomic dysregulation. And these, when there is an autonomic dysregulation, it can cause emotional behavior dysregulation. So, and when there is emotional behavior dysregulation, that can influence the autonomic dysregulation as well. So there is an interplay here between both of these aspects of the child's life. Tilly, can you just move to the next slide? So I'll just go through what are the kinds of emotional dysregulation, what are the kinds of behavioral dysregulation. So when you talk about emotional dysregulation, we are talking about various emotions which are either excessive or which are lower. So when you talk about excessive in terms of fear, if there is excessive fear, that is a kind of anxiety disorder where there is excessive fear. When you talk about mood, when there is lower mood, that is a kind of emotional dysregulation. And when there is emotional dysregulation, there can be associated behavioral changes. For example, a child with Rett syndrome may not be able to communicate to us whether there is fear or not. So they might show it in their behavior. That might be their expression of the face. It might be that they have excessive worsening of their stereotypic behavior, like, for example, hand-wringing movements. It might be associated with teeth grinding. It might be associated with certain behavioral features like agitation, and it might also be worsening of self-injurious behavior as well. So when you talk about emotional problems, dysregulation, that can lead to certain behavioral changes, and that can also lead to behavioral dysregulation as well. When you talk about autonomic dysregulation, autonomic system is a system in our body which helps to regulate various physiological processes. For example, how the regulation of our heart rate, the regulation of our breathing rate, breathing depth, the movement of our gut in terms of the peristaltic movement of the gut. So if there is autonomic dysregulation, the heart rate may either go very high, it can also go very in the lower side. When there is autonomic dysregulation, the breathing rate can change. There can be excessive rate of breathing. There can be shallow breathing. There can be apneic spells where there is loss of breathing control. So that is the kind of ranges of breathing difficulties which can happen. When you come to gastric problems, it can be constipation, it can be diarrhea, and these are the kinds of in terms of lower movement of the gut and more the movement of the gut. So let me give you just an example to see understand. For example, if a child has autonomic dysregulation and the child has a very high heart rate, and a person having such a physical high heart rate can experience anxiety. And that can experience as excessive fear in terms of the emotional. So they can sense it as very high and there is something bad is happening and there is this heightened fear. And that heightened fear can express behaviorally as a sort of excessive hand-wringing movement. It can be self-injurious behavior. It can be agitation, it can be aggression. So that kind of behavior problems as well. So in our clinic, we have kind of tried to integrate everything together into a term called emotional behavioral autonomic dysregulation. So yeah. So this is called EBAT, which we, in terms of a mnemonic, which we use is EBAT. And this is a useful construct which we feel in treating children with Rett syndrome and many other conditions like acquired brain injury as well. So when you consider this helps in us to develop a kind of a holistic understanding of their behavioral issues and their physical health needs as well in an integrated fashion. And that's why this construct is useful. And this, just to go back to some of the other symptoms which can present in terms of emotional behavior problems. Like I said, children can have phobias. Phobias are something which is very specifically to certain situations. For example, if they are alone, they have some, I'm sorry, okay. So if they are alone in terms of phobia, they can have certain situation can elicit fear. That is called phobias, where they can be alone in crowd when they're going out in other situations that can elicit fear. That is called phobias, that excessive fear associated with situation. It can be without any triggers. That is called panic attacks. It can be something which is like having a pervasive low mood kind of thing where they don't interact much, they don't enjoy things they used to do, they have this kind of social withdrawal kind of behavior. So that is all a part of the emotional aspects of this condition. And when you come to the behavioral aspects are something which is externalized, which is something more is evident outside. So it can be agitation, it can be excessive stereotypic behavior, it can be self-injurious behavior, and can be screaming, excessive rocking behavior, etc. And in terms of autonomic dysregulation, as I said, it can be breathing difficulties, it can be changes in heart rate. It can also be like, for example, changes in the skin color in the extremities. It can be in terms of temperature regulation in the extremities. It can also be, as I already described, constipation as well as loose stools, etc., and excessive sweating as well. So these are the kind of a whole range of symptoms which can present in such a fashion. And we try to sort of look at this in terms of clinically as well as as I will go through the next slides. I think Tilly, can you just, yeah. So just to show our experience in CPMRS, we have about 50% of children having anxiety and 25% having low mood. This just shows that there is a significant proportion of children having emotional behavior which might not be very apparent outside. And missing that and not targeting that for treatment can be having a huge effect on the quality of life of these children. Okay, I think we can go to the next slide, Tilly. Yeah, so this is the watch which we use regularly. Many of you might be aware. It's a sensor-based monitoring of the autonomic function using a wearable technology that is like a Fitbit kind of watch which we use. So Here, this was developed by Professor Santosh's team in terms of using that in children with Rett syndrome and building up the normal values for them and building up how to predict, how to interpret the result accurately. So this was, I think, it's a unique kind of thing which is being used, and this helps us get a sense of the internal environment of the child in terms of their autonomic function. And here we have this Fitbit kind of watch, which is worn, can be worn either in the wrist or in the ankle. And we usually try to have a longer recording if possible, as far as possible. We usually take 48-hour recording, and we have both day and night recording. That is also important for us to make accurate interpretation of the data which we receive from the watch. So what do we look at it in this watch data? So what we're looking at is something called heart rate variability. So it's a kind of measure of the variation that happens in the heart rate during day and night, and in terms of the highest heart rate, the lowest heart rate, the mean heart rate. And we kind of get a sense, we can use certain measures to understand whether certain aspects of sympathetic autonomic function is affected or not. For example, autonomic function has two major aspects, that is sympathetic and parasympathetic. That are the major aspects of autonomic function. And this parasympathetic and sympathetic has to function in a very balanced manner to have a good function of various internal organs. For example, if the sympathetic activity is more, the heart rate can raise. If the parasympathetic activity is more, the heart rate can go down. It should be in a particular balance to have a normal heart rate. And we can gauge from the data whether there is a parasympathetic overdrive or whether there is a sympathetic overdrive in the patients we see. And next is the electrodermal activity. That is also a sense of, gives a peripheral, what is happening in the periphery in terms of autonomic function in the skin. The electrodermal activity changes can be monitored. Usually there is increased electrodermal activity when there is some kind of autonomic dysregulation. And we also look at the wave which is formed from the electrodermal activity and try to see, we can kind of predict some of the causes which might be leading to the autonomic dysregulation in them. Because, for example, I think Samiya will be reading it with it later, but they might have certain physical condition that is driving this autonomic hyperactivity or autonomic dysregulation. And we can kind of get some clues about, based on the electrodermal activity, whether this is due to this kind of physical cause, or this is due to some other kind of physical cause, or this is not explained by any physical cause. So that kind of understanding can be formed. And also in terms of, we also collect data of the body movement. So that is just to correlate with whether any interaction is there with autonomic function and the body movement of the child. So if there is excessive, if the autonomic function can be explained by the body movement or not, and if it cannot be explained, that makes it more problematic or abnormal. I think this is what we are doing in terms of watch technology. Tilly, can you just go to the next slide, please? So finally, just this final slide before I hand over to Samiya. So what we do here is we try to understand the emotional behavioral aspects using our clinical history, clinical examination, and various clinical findings. We try to integrate everything together. We use the watch data to correlate the clinical findings with the autonomic function data which we have got. And based on that, we have some sense of like whether we should treat with medication and what kind of medication can be selected for this particular child. And then we also look at the blood and ECG data also, because choice of medication may depend on whether the child has certain ECG problems or whether the child has certain blood problems. Finally, we have a list of medication which can be used, and then we discuss with the carers about what kind of medication can be used, what are the options which we have, and arrive at a decision to start any medication if needed. So when you treat a condition as chronic as Rett syndrome, there are two things which a chronic and a condition like Rett syndrome, there are two things which we need to treat with medication. There are two things which are challenges. For example, one of the major thing is the high risks of side effects. Because the fact that the brain there is abnormal development of the brain, they are very sensitive to various medications. So we cannot use higher doses in them, and we need to be very careful with that aspect of that, that's sensitive to brain. Another aspect that causes high risk of side effect is the fact that they have physical conditions like cardiac problems or other conditions that may affect, that may make them prone for more side effects. So when we start a medication, we have this strategy of having we have a phase of where we do this medication stabilization and monitoring. So when we start a medication, we call the parents every week to check with them regarding the effects and side effects. And we try to achieve from this strategy, what we are trying to achieve is to have an effective dosing with as minimal side effect as possible. So that is the strategy which we follow to prevent side effects from happening. Another aspect is it's a chronic condition, and it may require a long-term treatment. So the problem with long-term treatment is that we need a proper collection of data over time. That is really important because these are something which is going to persist over a very quite a long time. And if you don't have what happened when the child was in different stages of her life or his life, then that affects the care, the quality of care they receive. So in this, we have the Professor Santosh has developed a health tracker. Is a web-based system where they have multiple questionnaires which are used to track symptom profile. For example, we use certain questionnaires which for parents and carers to know what is the symptom profile and how it is changing over time. And we also use things like checking with their in terms of for clinicians. We also use this health tracker to look at various drug interactions, because if there are multiple drugs, we put them all in and try to find which drug has the best therapeutic efficacy, and that helps us in further management. So we also have quality of life indexes in this health tracker system. So it's kind of a multi-informant kind of system which we use here, and it's quite important to use the system as frequently as possible for developing the best care possible for children and adults suffering from this condition. So that kind of longitudinal monitoring is very essential, and this is the method which we are using to target that aspect of the management. I think that's all from my side. I think Samiya can take over from now.
Thank you, Salah. That's a very good explanation. Now, moving on to the medical symptoms. If I'm going to list all the medical symptoms here, then I would require another hour. I think everybody would agree with me for that. But just to have an overview of what we are seeing in the CPMRS usually and how we are managing. So if you can see the two basic circles. So one is the area where we are able to directly help the patient by prescribing a medication or doing any strategies from our side. But there's another circle where it's just the monitoring that we are doing, or if required, we are referring them to the specialist, or in some cases, we are doing a change in our medication so that the effect or the side effect, we can take it off. So I think in CPMRS, we might not be dealing with all the cases, all the treatment that our patients require, but at least we are trying to do our best to monitor those symptoms and to refer them to the specialist whenever required. For example, if you see the symptoms of breath holding, hyperventilation, dystonia, spasticity, or it's drooling, in those conditions, we are able to prescribe certain medications which help. And we have seen a considerable amount of patients who have shown response to the medications that we have prescribed. So we are happy in a way with the response that they've shown so far. With regards to the high risk for prolonged QT, we were trying to monitor that regularly in the clinic before pandemic, having regular ECGs, and these ECGs were like not just one, we'll have certain like consecutive ECGs to check if there is any abnormality and to report and obviously refer if required. With regards to the sleep problems or teeth grind, which is usually associated with anxiety, we are prescribing certain medications which have shown some effect. With regards to the other symptoms where like epilepsy, they have a neurologist, but what we do from our side is to monitor it and see if things are changing, if they need a further referral, if there's something that we need to flag up from our side. It's similar for scoliosis or unsafe swallow. This is something that has been reported to us by parents. We make sure that if it's something that needs to be referred, we are there to take the appropriate steps whenever they are required. In terms of GERD, as we all already know that most of our girls do have this problem. Sometimes they're not picked up, they're missed. but we try our level best to get it from the history or from the examination, as we used to do before pandemic, to figure out if this is one of the problems that they have and it's being missed and it's not being treated. And obviously that results in a lot of impact on our children. Thinking about constipation or pain or low BMI or high BMI, in both cases, we try to refer them to the appropriate specialty. Next slide, please, Tilly. Now thinking about where our role comes in such symptoms, for example, epilepsy, yes, they are usually managed by the neurologist, but there are some imitators which neurologists said that they are not sure this is a seizure, so they usually call it as a Rett episode, autonomic storm, dystonic episodes, sometimes which are missed. So in those cases, it's our team who all sit together and discuss if these are the episodes and if they require any treatment from our side. Next slide, please, Dilly. So in the same way, the gastrointestinal symptoms, there are few drugs which can either aggravate these symptoms or they can kind of help with these symptoms. So in CPMRS, we try to look at all these symptoms and see if they are either getting worse, but by what the treatment they are already on, or do we need to, refer them further or start them on any medication, like, for example, drooling, for example, the pain. There are few areas where we are able to prescribe medication to help with these symptoms, but in some cases, we would like to refer them to a specialist. Sometimes it's somebody who is from their, the already care team, but sometimes it's somebody who is associated with CPMRS, and we try to refer them to the appropriate specialty. In the same way, we used to do, regular blood tests for all our patients, and monitor all their bloods if there's any abnormal liver function tests, because usually we see there is a difference, a change, which might not be abnormal. It might be something that's very common in our a patient population, but still this is something that needs to be monitored. So this was something that we were doing regularly in CPMRS before. Next slide, Tilly. Similarly with the cardiorespiratory, this is one of the areas that we have worked on, and regarding the breath holding and hyperventilation, and we have tried to prescribe medication which thankfully has made in a lot of our patients, with whether it's tachycardia or a high risk to develop prolonged QT. In similar cases, we used to do a regular ECG in our CPMRS before the pandemic, but currently we are requesting the GPs to do this regularly so that we can monitor, because with most of our patient population, it's missed. Like they have, most of our parents say that they had ECGs like 6 years back, or when the patient was 2-year-old. But this is something that we need to do regularly. And from our side, the role of CPMRS is to make sure that this is done regularly for all our patients. It's similar, with other symptoms, like if they have a high fever, if patients, present with the symptoms where we feel like that they need medical attention. So our role is to make sure that we do discuss this with the parents, we do refer them when appropriate, or the parents to go to an A&E whenever required. We are trying our level best to be available and to discuss it with the parents whenever it is required. Next slide, please. Other symptoms as well, like scoliosis, osteoporosis, we were trying our level best to make sure all our patient population is on vitamin D. Usually most of the parents are aware that these two things are kind of very prevalent in our population, but still these are being missed. There are few, some of our patients who are not aware of these things, but our role as a team is to make sure that all our parents are aware of this, and we try to monitor it either with blood tests, and if there are any unusual episodes like any fractures happening or any problems with this, so we refer them to the right specialty. Next slide, Tilly. Similarly, the other problems like sleep problems, which we are able to help with, we are able to prescribe few medications which can help them with their red nights, as you call. It's difficult. It seems like it might be simple, the sleep is disturbed, but these are quite significant episodes, and they tend to stay for a long time, and we are trying our level best, and obviously it's a learning, so we are trying to figure out what would be the best medication to use to help them with whether it's sleep, and at the same time, if this is a medication which can help with other symptoms as well. So kind of having one medication for a couple of symptoms to target. So that's the kind of the approach that CPMRS is currently having. Similarly, the pain, I think this is one of the areas which almost all patients, all our parents, they tell us that, there is pain, but we're not sure about the cause. So our duty here is we are trying to figure out if there is, any better way that what we are doing currently, if there's much better ways to figure out where exactly the pain is coming from, because this is one of the most common symptoms that we see. It could be related to dystonia, gastroesophageal reflux, with the teeth grinding, or some other symptoms. So our role here is to figure out what exactly is happening, and if they are in pain, like being watchers to figure out if there are episodes when they are in pain. For example, in the night, if they, just after their meal, they go to bed, they go to sleep, but after some time, the watch data shows that there are some episodes happening and they are in pain. We are trying to figure out if that is more related to gastroesophageal reflux and trying to treat that and refer to, as I said, to the specialty that needs the attention. And obviously with the low and high BMI, we want all our girls to maintain the skills that they have. I mean, I can imagine it's even a little skill like a smile is so important for us. So to preserve that's what we are looking for. So even if in terms of mobility, we want to make sure that if they have preserved the skill, they should continue to have it. So referring them to the dietitian if required for whether, increased or decreased weight gain. So this is something that we want to do from our side as a team. Next slide, please. So CPMRS care as a whole. So our aim is that we specifically figure out that this is a symptom rather than saying it's Rett syndrome. We figure out that this is a symptom which needs treatment. I'm not sure we would be able to give diagnosis to all the symptoms, but identification of a symptom and then specific treatment is important rather than saying it's a Rett patient and this is going to happen. We are also trying to make sure that obviously all our patient population is on like 10s and 20 and 30 medications. We are trying to make sure that we check drug to drug interaction and make sure that there's not, the side effects are not getting added up and, then having more side effects when we add more medications. Regular monitoring is something I know with our patient population, the frequency with which they see the doctors or the specialist is very low. We are trying our level best that we reach them whenever it is required. We are trying that, the service makes efforts to, cater these responsibilities in a much better way, but obviously we are still learning and we are trying our best to do it. Absolutely, for all the individuals, we cannot, as a disease, it might be one, but all our, patients are so different. Their response to medication is so different that we need to cater the needs of an individual based on their own, how they are, their response to the medication. They're all different. They might have the same diagnosis of Rett syndrome, but they are all different, and we need to make sure that their care is personalized as well. I think that's what I wanted to add. I would hand it back to Tilly. Tilly, do you want to add further?
Yeah. So I just wanted to add this slide in the end. Obviously, it's not kind of about symptoms necessarily, but another sort of part of what we do is the support around the family and the kind of education and social care aspect. So about sort of 35% of our patients are receiving some kind of family support or sort of support with local services at the moment. We're very flexible with this. We support the letters, going to meetings and sort of liaising with that side of things, which can be very important because I think it can really help with kind of therapies that are around that aren't necessarily medical. So, occupational therapy, speech and language, making sure they're getting the right kind of support at school to be able to sort of flourish the best they can. And that's obviously very important alongside all of the kind of more medical bits. And obviously we're all here for the patients, but their families are extremely important too. So we make sure that we provide that support as and when it's needed, through regular contact with the families, and also crisis support if, unfortunately someone's in hospital or there's a more acute episode, then that's something that we're sort of very conscious to support as well. as Samiya said, as a team, we understand that all our patients are so different. Like Samiya said, yes, all Rett syndrome, but they present so differently and respond to medication so differently that we know that their treatment needs to be personalized as well as it can be. And that's sort of definitely something that we work towards. So just at the end, just some disclaimers. Obviously, we're speaking from our experience and what we've seen. It might not be the case in everyone. The symptoms can present very differently from patient to patient in Rett syndrome. And obviously our treatment recommendations vary from person to person, hence why we're not able to provide kind of specific treatment recommendations today. And obviously, if you're concerned, always speak to your doctor. And if it's an emergency, please call 999. Oh, I ended it too fast, but any questions?
Can I just say that I think that was a brilliant, really informative session, and you explained, all three of you explained all the elements of CPMRS so well. Thank you very much for this overview, which I found really helpful, and I hope everybody else has too. A lot of the time at Reverse Rett, we struggle to explain CPMRS concisely. But you've done that, and we get a lot of positive feedback, obviously, at Reverse Rett from patients and families. If you don't mind, I'll start with the first question. Beth, is that okay? I can't see you right now. Okay, yeah. So just thinking about the feedback that comes from the patients and families, one of the things I've heard this week is that the team has actually been able to help a family with sort of social services support. And I think there's nothing that's more helpful in that situation than having, medical input to say that you need additional respite or what have you. And I just wondered, of the patients that you have, obviously, I think you see more complex patients, but of the patients that you have, are there many that don't have any intervention from social services that you can see? And are you able to help facilitate that happening? Because we do see it Reverse Rett, especially with patients who have remained not very complicated till they get bigger. Sometimes they've not had any social services support in terms of respite or anything, care or anything, until they're about 14, and then suddenly they have problems.
Yeah, I think we haven't seen too many that don't have any support where they want support. We have seen some people who don't have any sort of carers or respite, but that's an option that they're happy with at the moment. They're waiting until, maybe their child's a bit older and they feel like they need it more. So I haven't seen too many that don't have anything and they need it. But there's definitely quite a few people that we've seen who have maybe needed a bit more or a little bit extra sort of care, especially during the pandemic. Obviously, everyone's at home, carers might not be coming in. So, we try to support that best we can. Obviously, we can't wave a magic wand and say that a letter from us or a call from us is going to implement stuff. But obviously, when we write supporting letters, things like that, we make sure we cover sort of every element and make a strong argument as we can, alongside other colleagues doing the same thing. So I think we've had quite a lot of success with helping families get the care that they need.
That's brilliant. And another thing that I just wanted to highlight is, I don't think that this message about sensitivity to medications is getting out. And in Rett syndrome, I think that a lot of the time people are trying things locally that they go on too quickly, and then people think that medicine didn't work because it's made obviously loads of side effects. And I don't think this is just a Rett syndrome issue. From my observations, it seems to happen across the board when everybody is prescribed medicine. They're just given a blanket sort of recommended dose, and then sometimes people are, it's too much for someone. So what I'm wondering is how is the centre working to try and get that message out to people that that you do need to do this kind of, what did Salah say, medication stabilization and monitoring? Because although and this is something that we need to highlight as well, and although the CPMRS monitoring is open to everybody, so for people who are here today whose person with Rett syndrome is not under the centre, that is something that's possible. you just need to let us know, either myself or Tilly or Beth or anybody here in the chat even, if you're interested. But there are some people who are just not properly medically managed by the centre, if you see what I mean, and they need to change medicines and so on, and they're just being given super high doses. So how was the CPMRS working to try and get that info out? Who's going to answer this?
Samiya or Salah wants to take that as more medical.
Yeah, I can only tell from what we are doing in terms of our patients, which we have already. So what happens is we do these assessments completely, and then we look at all the medication, and then we kind of recommend certain changes in some of the medication, maybe add something which is needed. And once we add the medication, we kind of, as the philosophy is, as because the sensitivity of the brain, we don't give the recommended, or we give a lower kind of recommended dose as a final target, but we still start from very low dose and slowly add up that dose to reach that lower target itself. And then we have this audio conferencing calls. We call them up and check on them every week, weekly calls, till we are at a stable dosage. So, and then we do follow up, but not as regular as that. So I think that's the kind of work we are doing in the patients coming here, but I'm not sure about whether is there anything like in terms of getting the message across. In terms of publication, we are doing that kind of, but I don't think in public literature, I don't know how much is being done. I'm not sure about that. Maybe
I probably worded that question badly, because I feel like what I needed to say was, how can we work together to get this message out to the Rett community? And hello, Professor Santosh.
Hello, hi. I just wanted to, I was just in the background. I didn't want to interrupt till this particular question came along. But the thing is that the model that we've developed about the minimum effective dosing strategy, this has been published way back in 1990s, late 1990s, that we published the model. And at every sort of conference that I attend, or anyone in my team attends, we actually do promote the model. Initially, when we started off, it was almost 2 decades ago, when people used to think we were practicing homeopathy and saying this is not science and so on. But over the last 7 to 10 years, it's become very clear that what we've been doing is absolutely what is needed, because the sensitivity of the receptors in rare diseases and where the brain has been involved is very different from what a typical textbook tells you to do. And so the other thing to understand is that we don't have much evidence that any medicine works, because we haven't done clinical trials. So the one thing that as a doctor one needs to do is, at least you should not do harm. And so the basic scientific principle is that you start very low, go slow, and monitor very carefully, with the view that if any side effects occur, you can actually then reduce or stop, so that you don't add problems to the patient, because there are very few medicines in rare diseases that we actually have clear-cut clinical trial data to suggest that it actually works for the core symptoms. So for epilepsy, it's different. You have data for particular things in terms of epilepsy, where that anti-epileptics are needed for epilepsy management across the board. But if you're looking at, is there a study that has looked at anti-epileptics specifically in Rett syndrome, there isn't one that you can actually point to and say, this particular anti-epileptic is better than that or the other. And so when that is the case, that we have to be upfront and say, when we're talking about medications, is that medicines help generally. However, it has to be used appropriately and monitored very, very carefully. Just as an example, this has got nothing to do with the thing. I started with a statin, and 4 days later, I had a major side effect, which then meant that I had to come off it and get investigated. Now, the issue is that if I wasn't aware that that particular side effect was possible with this ordinary, simple, medicine, which would, which lots of people would be on, I wouldn't have picked it up. And if I hadn't picked it up, I would have ended up in a situation which would have been far worse than if I had. So the issue is about being able to, the principles are very simple. Any medicine, when it's being started, start very low. Our principle is that start roughly 1/8 of the dosage that you think the person might need, and then increase it by 1/8 every week and monitor and see whether the person actually requires the same dosage that you thought would be needed, or whether they can actually get away with smaller doses. And if they get, and you can get away with smaller doses, you should prefer the smaller doses, because ultimately it's a chronic illness and medicines may need to be given long term, and so side effects will build up, so therefore we need to be using it more cautiously. And that's the principle, and that's the principle that the CPMRS uses. However, it's not a very easy message that has been gone out there to everyone. In autism, there is a campaign called Stamp and Stomp, STAMP, STOMP, that is very specifically looking at medication use in autism. And my view would be that we should probably try and develop something similar for rare diseases, which could then, it's a campaign that has gone through to the Parliament. It's got the NHS England backup for it and everything. However, for all of that, what we don't have is the teeth to be able to monitor what's happening. So for example, in the CPMRS, we use the profile of treatment response on the health tracker, which allows us to see what has happened across the whole lifespan of the patient in terms of medication response and side effects, which then helps us to manage the patient much better. Now, so that sort of an assessment medication review, structured medication review, is essential for all patients, but it is not really being done very well. And because the other thing is that when you don't have continuity of care, if you're seen once a year, you may see the same person, you may see someone else. And so therefore you don't have the continuity of care, which I think is one of the big differences in the CPMRS. You have continuity of care. So you have the longitudinal ability to look at what has happened, what decisions were made, and how it was made. So I think that particular aspect is something that we can work with Reverse Rett and others to try and develop, because I think it is an important aspect which has probably not got the sort of central sort of thing as it should.
That's very helpful. Thank you.
No problem. Thank you.
Does anyone else, I'm aware that Rachel and I have written some questions and I've scribbled a few down on a notebook as well, but does anyone else have any questions that they'd like to ask? I don't want us to take over with the questioning. Nope. Okay, well, I had one going back to what Salah was talking about, and Rachel also expressed in the chat. It feels quite sad that that our children have this intense fear and anxiety, and I was kind of struck by a sense of, well, chicken and egg situation. So, and sorry if this is a really stupid question, but which one comes first? So does the condition cause the autonomic dysregulation, which then leads to fear and anxiety? Because obviously you would feel anxious if your heartbeat was through the roof all the time, or if you had these dysregulation going on. Or do the children have fear and anxiety from the very nature of frustration, for example, or any of the other more behavioral issues that come with the syndrome, and then that anxiety and fear causes the autonomic dysregulation? Which way round is it?
So I'll just say what I feel about the issue. That's a good question, and it's like a chicken and egg situation where, but what we can say is the experience of seeing the patients. So when we see a patient who have kind of very significant autonomic dysregulation, I think in the clinic, what we do is we try to treat that first. We focus on that. And some of the medication which treats this autonomic dysregulation has an effect on, additionally on the anxiety as well. So it is not just the autonomic dysregulation, but there may be situations where there is no autonomic dysregulation, but there is only emotional behavioral issue, and in those cases, then we have to change the medication appropriately to target those as well. So as far as clinical purpose is concerned, this is what we follow, but we don't really know the intricacies of the exactly what happens first in it. So, and again, it's not that all children might have both of the issue, or it's not that every children has all these issues. So it again comes back to personalization of the medication to that child specifically, and that's what we try to work. I think
Yeah.
maybe
And also, I think the other aspect of it is that in terms of the autonomic dysregulation, it's a central core component of Rett syndrome. And that's partly to do with the fact that there is a slightly immature brain stem where the cardiorespiratory center sits, where the monitoring of the autonomic and how you breathe, how your heart beats, that part of the brain is not as mature as it should be, and that's something that has been shown repeatedly. So the question is that so they are much more prone to autonomic dysregulation, where right from temperature changes, peripheral vascular changes, heart rate changing rapidly, breathing difficulties, hyperventilation, apneas, all of those are actually part and parcel of autonomic symptomatology. The one component of that is the emotional part of it, which is where the anxiety or the behavioral issues come up. And so Salah is right that some of them may not have a very marked physiological response, but may have a psychological aspect of it. So the best way to look at it is that in a biopsychosocial model, when you look at it, biologically, Rett syndrome patients are more vulnerable to emotional and behavioral difficulties because they've already got a preset brain disorder which makes them more vulnerable. So that's one. And the second component of it is that because of the anatomical and physiological differences in Rett syndrome, because of MECP2 as such, it makes them more vulnerable to autonomic dysregulation. And so therefore, autonomic dysregulation is a physiological construct which is present. It transcends a single system. It can, because of autonomic dysregulation, it can have an impact on the gastrointestinal. It can have an impact on the respiratory. It can have an impact on, peripheral vascular, on emotional, all of those things. So if we look at a biopsychosocial perspective, the biological perspective is where you use medication and other things. The psychological is where you actually end up having to use the psychological wraparound to be able to enable the child to be able to function at their best. And the social is the bit which we've been discussing a little bit about, is ensuring that the environment in which the patient is and the family is actually best supported to be able to reach their ultimate, and the ability to participate in all things that they should be able to. So it's actually the best way to look at management is biopsychosocial. Even if you look at COVID at the moment, it is a biopsychosocial problem. It's not just a virus problem, because if there was no overcrowding you wouldn't have this massive resurgence of COVID in developing countries. And so that's a social problem. That's not to do with the virus. The virus happens to be the biological component of it. The psychological component of it, there might be some individuals who don't either believe or who are afraid and so on. So the personality-wise, that whole thing about the psychological aspects of it have to be managed. So if you want to get truly to any condition, you really have to use the biopsychosocial model and not underplaying any one aspect of it. And so that is why in CPRD and CPMRS, when we're doing it, we use the approach we use is actually, it's multi-axial when we're looking at it. Yes, there are some psychiatric problems, there are some medical problems, there's some genetic problems, but there are also psychological, psychosocial factors, and there are social circumstances that have to be addressed. If any of them are not addressed, you're not going to get the best outcome for that child and family. And so it is that model of biopsychosocial model, I think, is what is needed. And that would be the same whether it is for managing epilepsy, whether it is for managing constipation. It doesn't matter. It could be a whole lot of things. It could be just the fact that they've started periods and there isn't someone in the home who can actually manage the periods because there's only a male, and the person who's actually, the dad, is finding it difficult to do it. And so there are lots of those issues that have to be done. about it.
I
Rachel,
think that's
sorry.
really a helpful answer, Professor Santosh. And, you know, this just, you know, having had a daughter with Rett syndrome for 20 odd years, this is the kind of care that I've always felt people with Rett syndrome need and the family needs.
Yeah, exactly.
So it's great to have this available in the UK, and you know, eternally grateful to your team for what you're doing. Okay, Beth, over back to you before I go on.
No, thank you. Yeah, ditto what Rachel said, because it's I know other parents here have their children seen at the CPMRS, but I know that for us, it's the first time of going into coming out of an appointment and feeling like somebody had actually looked at our daughter as a whole picture and as a whole person, and not just one specific symptom that could be easily, you know, dealt with a tube of pills or something. And it just makes a massive difference. I know we're a little bit short on time. I'm just going to try and pick something. On a very practical level, the health tracker and the questionnaires have been mentioned a few times, but I just wondered if one of you could explain for anyone who doesn't have access to them yet or know about them, as to why they are so critical and how they are useful both to the person who's filling out the questionnaire, but also to the wider Rett community.
Okay, I'll take that. It's in the health tracker, there are some questionnaires which one is we've developed the questionnaires alongside with Reverse Rett and families themselves. So we've co-produced a questionnaire called the REST, which evaluates Rett symptoms across the board. And so that particular questionnaire, we are asking families whether they could complete it probably 3 times a year, which means that we can actually follow what's happening to the child across time. And that is for anyone who's registered with the service, they can do it. And it's just remote. You just go on, you're sent a link, you've got a password and an ID, you go online and you do it. That particular questionnaire will probably take you, the first time it might take you around 20 minutes. The second time it'll take you 15, and after that it becomes much easier because you've got to understand what the questionnaire is like. Apart from that, we've got a questionnaire which is just a 5-minute questionnaire. It's just the symptoms that we've identified that can be picked up as change quickly. Those questions, just 5-minute questionnaire, which can be done at any time. It will always be available on the system, especially to be completed at least once or twice, so that we know what the baseline data is. And after that, it's always available, so that if the family feels something is changing or they're worried about something, they can go online and just do that 5-minute questionnaire. Because the importance of that questionnaire is that questionnaire, we've developed some artificial intelligence algorithms in it, which then sends off an email to us to say that this particular symptom is above what you would expect for this child. And so if that is there, then we get the email and then we can contact the person and then work around what is happening and work in real time. Apart from that, we've also got a questionnaire about parental burden themselves in terms of how the parents are doing. And that has got a crucial role in our team, because from that, the psychologists are able to identify the parents that need more help and can be provided that in a more timely manner. So those are the sort of actually at the patient level, how it is going to be useful, because by completing it, it helps us monitor and it helps us to deliver care in a more appropriate fashion at the right time. So that's one. The second part of it is that for the purposes of us being able to hopefully come up with a model where we can get NHS England or someone else to agree that this kind of care is needed, we also need to collect health economics data to show that whatever is being done is actually having a positive impact on the family. So that we collect. There's the questionnaire which we try and do once a year, where we actually are asking what are the kinds of services you'll have received, what are the problems with it, and so on and so forth. And so that is something that we ask the families to do once a year, which is to collect data so that we're hopefully able to change practice and we can actually use it to advocate for the condition. So those are the kind of things which are there. And then when it comes to more specific things like COVID, we had developed a COVID questionnaire specifically for Rett syndrome, and we'd asked for people to complete it. But that has been done. We've got the data that has helped us immensely to make decisions about things. And I think that has been useful. And this 5-minute questionnaire, I think, has helped us immensely to be able to prevent patients from needing hospitalization, because as soon as there would be fever or breathlessness getting worse, we would get the automatic alert coming through because of the algorithm. And so we would contact the family proactively. And so then we could work out what was needed, whether it was COVID, whether it was not, how to manage it. And I think that has been hugely useful, because there's very few examples in the NHS where digital health has had a direct impact in real time during COVID. And I think we've been able to demonstrate that. So that's the kind of thing. So it's the health tracker is a platform. You can complete the question on your phone, on your iPad, or on your computer, whatever it is. But it is the whole time that we're asking of you would not take more than half an hour maximum, once every 3 to 4 months maximum. And often it is much less than that. And what is needed is that the ability to understand that this 5-minute questionnaire is always available. So as soon as you feel that there's something not right and you want to get us to understand what might it be, you just go online and you can complete it, because that questionnaire is always available. As soon as it's completed, and if the scores are abnormal, we will get informed straight away. And then we will be in a position to contact you all. So that is the sort of summary of what the health tracker does. And apart from that, for the clinicians as such, we've got aspects which are not directly that the patients have to do, but clinicians, we've got a very structured medication review module in that, which means that the doctors go through questions with yourselves about what medicines were given, when it was given, what is the dosage, what side effects, and so on. And that gets put into the system, which then means that it allows us to look at which medicines are safe for this child, which medicines are unsafe, and which ones should be monitored, which ones should be stopped, and so on. And that allows our team as clinicians to be able to provide better care. So there's a component that is for clinicians to be done, that is within the team. They ask questions and they do. The bits which the families have to do is the bits which I've mentioned. And it is not more than 3 times a year that we're asking anyone to do anything other than this weekly questionnaire is always there. You just do it once or twice in the beginning, so we have a baseline. And after that, it can be done by families at any time that you'll want to.
Thank you. And I think for anyone who isn't already doing those, I can include probably a link in a follow-up email if you would like to access them.
Yeah, and sorry, and the last thing is that when we get group data from large numbers of patients, then we can actually do analysis, and that allows us to learn more about the condition and then change practice if needed and improve care. Ultimately, it's about learning from data to improve care for patients that need it.
That's brilliant. Well, I think that was such an informative and interesting session, everyone. So thank you very much to Dr. Samiya, Dr. Salah, Tilly, Professor Santosh, and to everybody else for coming. If you have found the session helpful, please do leave, Beth will send out a survey, which people aren't really filling out. It really helps us if people do fill them out. If you don't have time to fill them out, please just leave us a comment in the chat so we know we can gather information for funders about these sessions and how helpful they are. The next session is next Friday, and it's on eye care and vision with Dr. Gail Gordon, who is an optometrist, excuse me, but also the mother of a daughter with Rett syndrome. And then the May sessions will be slightly different. We're doing panels with parent experts on speaking on different topics. So for example, the first one is scoliosis surgery. And then, or just scoliosis, including surgery. And then the next one is gastrostomies, and then we have one on reflux. The dates and the details to sign up will be sent to you after this session. We also have a family forum, which is more of an informal online meeting that we've been holding on the 12th of May, and those details will be sent to you as well. Thank you very much, everyone. It's really good to see everyone and to hear all of this positive stuff that's going on, not only for the individuals who are using the centre and being monitored, but for the broader Rett community, that so much information is being gathered that can improve outcomes for people with Rett syndrome across the board. So thank you for all this work, and thanks everyone for being here.
Thank you.
Thanks, everybody.
Goodbye.
Bye.
Bye-bye.
Well, how did everyone find that? Everyone who's still here, you're very welcome to stay. I just wanted to free up the clinicians.
No, it's really interesting.
Yeah, good.
Yeah.
So Rita, did you find that interesting too?
It is very interesting and very helpful. Thank you very much. I'm glad that I joined.
Good, I am glad you joined too. Do you have a daughter yourself?
Yes.
How old is she?
She's 10 years. She's at school at the moment, yeah. But a few of the questions that I have, it did help me. She's crying a lot these days, and I was just wondering why she's crying. She used to do that when she was young, like 1.5, 2 years old. She used to cry very badly. And now that that sort of phase is coming again after 9 years of time. So I was just wondering why she was doing that, but I just got some type of information from this, and it is very helpful, very, very helpful.
And it also could be a bit of hormones creeping up now, couldn't it?
Yeah, that's what even I was just thinking. A tough road ahead.
Yeah, well, one thing that they have noticed at the center is that people with Rett syndrome sometimes seem to have early puberty. So they get, you know, it happens quite frequently. And then there's also like a third of people that just don't seem to menstruate, or they have, you know, one period and then they go away completely and they don't really know why. So I think when as they collate all this information, see more and more patients, some light can be shed on some of these things.
Yeah. Is this possible, the recording? Can we get this one? Can we get a share of this? Can it be shared to us so I can share with her teachers, the class teachers, and they can have the information as well, and they can understand Varenia why she's crying, or they can understand her better.
Yeah, absolutely. We'll send that out to you next week, and I'll also get the slides and send them to you as well. Just
that would be fantastic. Thank you very much. I would like to join the next eye session as well, but unfortunately my daughter has an appointment. She has the vision issues as well. She sleeps with half eye open and she's having scars in her eyes, and she is recommended for the surgery. So I do wanted to attend that as well. But,
so Rita, if you sign up to it anyway, if you sign up, then you'll receive the email afterwards with the recording. So then you'll still be able to watch it. So just sign up to the session online when you get the link, and then you'll be included when you get the recording afterwards.
And if you have any questions, just send them to Beth and we'll ask them.
Yeah, if you want to send questions, you can email them through to me, and then I'll ask Dr. Gordon those on Friday, and then you can watch the answers back.
That will be very helpful. Thank you very much. I will do that.
Where are you based, Aretha? Where do you live?
I live in West Sussex, Crawley.
Okay. Yeah. Not too far.
Yeah.
Where do you live, Dawn? I don't know where you live.
I'm very near you, Sarita. I'm down in Worthing, so South Coast. Yeah, it's literally straight down from Crawley. So.
Oh yeah.
Nice.
Sorry, Erin's speech and language therapist rang, and it was kind of like, yeah, can't miss that one. So.
That's okay. You'll get the recording as well.
Yeah.
Can anybody think of any other topics that you would like for the future? Because we're only going to do one more after May, which we just agreed this morning, because it kind of snuck in, like a respiratory thing. But just later in the year, what would be helpful?
I know that transition has been mentioned a couple of times, and also we were planning to do some on clinical trials, practicalities, but any other topics are?
The two topics that I'm interested are getting covered. Scoliosis is on my list, and vision is my which I wanted to know. Both are getting covered, so I will just enroll for both of them.
That's very good.
Yeah, I'd be interested in a transition one as well.
Yeah. How old is your daughter then?
She's 13, but you kind of feel like you have to start all these things early.
Yeah. Mine's 40.
Definitely.
I'm starting to get nervous.
And I can't believe that Georgia will be classed as being in secondary school next year.
Yeah.
Time just seems to be flying by, and like I say, before you know it, it will be time to be thinking about that next phase.
Yeah. Yeah. Hannah's technically going into year 10, which,
Yeah,
you know, that's GCSEs and scary, very scary. Yeah, but like you say, Dawn, I think everyone I've ever spoken to has said you need to start around 13, 14 thinking about transition. So
yeah,
start biting the bullet.
yeah, just get my head around it, because there's a lot to sort of think about. I think Erin is definitely going to stay in the same school at least till she's 19.
Yeah,
that's so.
good.
At least that's comfort.
Yeah,
Yeah.
that's good. It's just like, what do you do after that? That's the.
And also maybe one about, and I don't know if these are the right words, but power of attorney, because obviously when she becomes an adult, I think again you need to, I would need to, I think there's forms I need to fill in to make sure that I'm still her advocate or in charge.
Yeah, that's good.
Yeah, we could. I think we could try and cover those things. Maybe a couple of. I think we'd need at least a couple on transition. Actually, maybe some with some kind of professionals in the know, and then some parent panels who've got experience of different routes. You know, we know parents who've gone lots of different routes, and it's useful to hear from them, I think.
Yeah, I think so. Well, yeah, again, thank you everyone for being here. I have to go now because I'm on to another call in 5 minutes, but it's really nice to see everyone.
Yeah.
Okay. Thank you very much.
Thank you.
Take care, everyone.
Bye.
Bye.